And it's an absolute pleasure and honor for me to welcome once again Dr. Barbara Spivek, who is the president and CEO of MCIPA. We're thrilled to have you as always, Dr. Spivak. And first of all, I just want to say thank you very much.
Well, I want to say thank you for having me. I've always enjoyed these talks that we have. They're usually very provocative and they make me think about things in a slightly different way. So I'm happy to be here. Thank you.
Wonderful. Thank you so much, Doctor. So for those who aren't totally familiar, can you just briefly describe your organization, obviously your role as CEO, and then we'll talk a little bit about what's been going on at MCIPA. But please explain to us just in a few minutes about your organization.
Well, first of all, I'm a primary care doctor in Watertown, Mass. I've been in the same office building for 36 years. And as I've aged, I'd say my practice has aged. So in many ways, probably 30% of my practice is over 70 at this point. I've been running the Mount Auburn Cambridge IPA for about 24, 25 years. And we are a physician organization affiliated with one hospital in Cambridge, Mass, Mount Auburn. Mount Auburn is about a 180-bed hospital. It's a community hospital that has a mixture of community services and tertiary services. So we have a very sophisticated cardiac program that includes open heart surgery in TAVRs and a pacemaker unit. We are comprised of both employed physicians, so primary care and specialists who are employed by the hospital, and private physicians. When we started the IPA years ago, it was mostly private docs. And over time, particularly with COVID, we are now a little more than 50% of our physicians and advanced practitioners are actually employed by the hospital or the system. We do risk-based contracting and have done that since the 80s. We were the first group in 1994 to do a Medicare Advantage contract in the state. We were one of the first 32 pioneers, and we've done risk-based contracting in Blue Cross, Harvard Pilgrim, Tufts, obviously the Shared Savings Program now, and Medicare Advantage.
Wonderful. And you've been leaders for so long, and tell us just a little bit about the last year or two and some of the business arrangements that might have evolved forward, some of the contracting that might have evolved forward.
So, Massachusetts is an interesting market, and Mount Auburn Hospital became part of a system, BI Lahey Health. And so it is now the hospital and the employed physicians are no longer employed by Mount Auburn, but they are employed by a 13 hospital system called Beth Israel Lahey Health. My organization, the IPA, still is an organization of half employed physicians, both primary care and specialists, and half private. We were not bought out by the system. We are just affiliated. And there are other groups like ours in the system where there's a combination of employed and private. So we created what we call the Beth Israel Lahey Health Performance Network that has its own board. It is a subsidiary of the system. So this is a hospital-based system with physician groups like mine affiliated with it. And that's been a very interesting transition. My organization has been completely independent since inception in the mid-'80s. And now we are part of a bigger system. And so
And how many physicians are in the consortium?
well over 2,000, 2,500. And we're only about 10, 12% of that.
I see.
And, I think it's been a transition. We still have our own board. We still are independent, and some of our contracts still are separate from the network. So our shared savings program is still separate. Our Medicare Advantage program is still separate. The network has a Medicaid ACO, which we do not participate in. The Medicaid ACO preceded the formation of the network. And when we looked at the Medicaid ACO for our organization and hospital, we opted out of that, primarily because we didn't have the behavioral health network that one needs to do a mass health ACO.
I see.
But our Blue Cross and Harvard Pilgrim contracts in 2021 and going forward now run through the network, which means they do the contracting and then we do the medical management. But it has been an interesting transition. There are 13 hospitals, 13 different physician organizations. Each of us treat surplus, our fund differently. Our funding for our organization is done differently. For example, many of the 13 groups charge a membership fee in order for physicians to belong. My organization, McIPA, has never charged a membership fee. We use surplus to fund the organization. So we are delegated, unlike some of our other risk units in the organization. We've been delegated by the health plans to do medical management. So the health plans pay us, and then we use surplus to fund the difference. Our services are slightly different. So some of the parts of the network only do telephonic case management, where our case managers, our social workers, and our health coaches are all embedded in the primary care doctor's offices. So it's been a transition, and it will continue to be a transition over the next few years as our contracts evolve and as we learn to work within a system.
Absolutely understood. So I'm going to ask you a question in a very subjective way. How does it feel right now? Is it more challenging, less challenging, just challenging in a different way, just more complex compared to when we talked 2 years ago?
It's definitely more complex. I think that as we become part of a system, it's a culture shift for our providers to understand, for example, something very simple, which is in previous years, we looked at all of the healthcare that went out of Mount Auburn. But now that Mount Auburn is part of a larger system, it is less important that the business all go to Mount Auburn. What we can't do at Mount Auburn, we now want to stay and go to B.I. Leahy Health physicians, and stay within the network. So many of our providers were used to sending patients to Mass General Brigham. We are now really very much moving those providers into thinking more about using Beth Israel Leahy Health providers. That's one example. We don't get data in the same way. We have our own data warehouse, for example. We now are using an Arcadia, which is another data warehouse that has been built for Beth Israel and their system. They use data in slightly different ways than we do. So we are currently still maintaining our own data warehouse as we're working very diligently with the new network to make the new data warehouse work for us in the way we want it. So it's been a real culture shift.
Mhm.
You know, for me personally, it is difficult sometimes to realize that things that we've always done and done successfully are now going to have to be tweaked to fit into the quote network.
Yeah.
Um, it's for the staff of my organization, because remember, my organization has over 40 staff people working. They've had to get used to a different method of getting data. It's not going to someone around the corner or picking up the phone and saying, Kathy, can you run me this report?
Yeah.
It now has to go through a system and get into a queue. So
Right.
there are many cultural changes for us
Yeah.
that we as an organization have had to live through and will continue to have to live through.
Absolutely. As I like to say, more chefs, bigger kitchen.
But on the other hand, you know, this is an environment where a small hospital and a small physician group in the middle of a very complex healthcare environment with competing organizations, not just Mass General Brigham, but Steward and some independent hospitals, it's becoming harder to survive on your own.
Yes,
And without the
absolutely.
support of a bigger network, we would probably not be able to get the kind of contracts that would allow us to really survive and deliver the quality of care that we want. We still focus really heavily on improving the quality of care that we deliver. And, you know,
Exactly.
the pandemic has certainly changed that as well. And I can talk about that in a minute. But without having the network behind us, I don't think we'd financially be able to survive in the coming years because the commercial plans just wouldn't give us the kind of contracts that we need.
Yeah, I completely understand. And what have been the biggest challenges in all these changes?
So I think the biggest challenge is actually the financial one, because when you think about what happens in a system contracts with, let's say, a commercial health plan, and the commercial health plan gives them a budget that's a bucket budget, and then we have to decide how to allocate the budget, how to allocate infrastructure dollars, how to allocate surpluses and deficits. We have to figure out, how do you look at groups that do different levels of service? And, you know, how do you balance private and employed physicians? Do the privates get exactly what the employed, and who pays for that? You know, it's the financial ramifications. It's easy to figure out how you're going to divide all of that up when you're in one hospital, one IPA, you know, multiple. We had 85 different offices in MacIPA, but one board. It's easy to figure out how you're going to do the money when it's simple. Now it's much more complicated, and it requires a lot of thought and constant tweaking.
Understood. What, can you name a few of the accomplishments you feel most proud of in the last couple of years? It can be anything related to quality or measurement or analytics or finances or anything.
Well, I think the way we handled the COVID crisis as an IPA was really remarkable. So the first thing is everybody suddenly shut down. Primary care, specialists, urgent care only. And most of our docs, me included, had never done any kind of telephone visit that they got paid for. There was certainly no ability to do a video visit. 99.9% of our docs had never done a telephone video visit or even a telephone visit that they paid for. Getting all of that into the computer, putting in smart sets so that people could type in .telehealth generic and get a spreadsheet that told them what information that they needed was really, took very little time. Do you want to stop for a second and I'll turn can you hear my
Yeah,
telephone?
that would be great.
Hold on.
And I'm going to put a, yeah.
I apologize. I haven't gotten a phone call in days.
No worries.
No
We
problem.
can usually cut that out. Mark, do you want to start from the beginning of that question?
Yeah, that's what I'm going to do. And also, I was having a weird problem I couldn't tell you about, but I'm putting in a yellow cable just to make sure that I'm not going
Yeah,
to have
you
any
froze
problems.
a couple of times.
Yeah, and
Yeah, we can cut that out.
Yeah, that's what I figured.
right, I got the message saying your internet connection is unstable. I really hate Comcast, but we won't put that into our discussion online here. So I'll just start, Dr. Spivak, I'll just start with, tell me about a few of the things that you're most proud of that you've done. And then, because that's, you were
Right.
pretty continuous after that. Okay, you ready?
Yeah.
So, Doctor, tell me about a few of the things that you're most proud of in the last couple of years that you've been able to accomplish, and it can be any kind of accomplishment.
So I think the way we dealt with the COVID pandemic, particularly in the early days, was extremely impressive. We worked very collaboratively with our EPIC IT department. We worked collaboratively with the hospital. And let me give you a couple of examples. None of our docs had ever done telehealth, whether it was with a video component or audio only. And we worked really hard to teach all of our doctors how to do telehealth. We worked with the IT department to put in a smart phrase that so that doctors could type in .telehealth, and all of the requirements to have a billable visit were there. We recognized that many of our older patients did not have legally binding advance directives. And we worked with legal to make sure that when people had telephone conversations with patients and their families on the phone, either video or audio only, that it was a legal document that described what their advance directives would be. We got that up and running very, very quickly. We also decided that we had to figure out what did we want to focus on in quality, because you couldn't do colonoscopies, you couldn't bring people in for blood pressures, you couldn't even bring people in always for blood tests. So we decided to focus on high-risk patients. So we looked at and ran data that said these patients were ones who were not in control in 2019 and early 2020. Or these are our patients who had high-risk combination of illnesses. They had heart disease, diabetes, pulmonary disease. These are the ones we wanted to reach out to and make sure that they got care. The hospital was willing to set up a very vibrant ambulatory blood drawing center, so people could go safely, masked, into a building, get their blood drawn, and then the next day do a video visit with their provider. And what we found was that we really were able to take care of our sickest patients. There was a problem in the beginning of there weren't enough home care nurses to be able to go into people's homes. The hospital was full, and many of our primary care doctors volunteered to go into the hospital and work as hospitalists. There were hospitalists who had to leave because they got COVID, or they had family members that had COVID. And so we worked very clearly with the hospital to make sure that the hospital was covered. And I think that showed a remarkable ability to collaborate quickly with all the elements of home care, IT, hospital, and physicians, employed and private.
I think that's absolutely wonderful, doctor. And one of the things that everyone has told me, and I certainly want your input too, but people have said, first of all, no one expected a global pandemic to hit us, right? But given that, what happened showed us, many CEOs, CIOs, CFOs, COOs have said, it showed us we can actually move fast if we really have to, right? In healthcare, we always say healthcare is incredibly slow moving. It's unique and uniquely slow moving. Well, a huge crisis happened and organizations did move quickly. It wasn't always graceful, but people did what needed to be done. And I think there's a hopeful lesson from that, don't you think? That we are resourceful. We are resourceful people in healthcare.
I think that our ability to vaccinate an entire community as quickly as we did was also, not something that my IPA did, but certainly the state was able to put up these huge, Gillette Stadium got turned into a vaccination center.
Yeah.
The hospital took staff who were at home, unable to work, and put them into these big sites where people could go and get vaccinated. Healthcare providers were vaccinated extremely quickly.
Yes,
To
absolutely.
protect them. And I think that was remarkable. We don't do that with the flu vaccine. It took months to get people vaccinated, but when we had to do it, it was remarkable.
Yeah, absolutely. So if I may, doctor, I'd like to shift to another subject, which is policy around alternative payment models, APMs. And you and I have had such great conversations in the past about this. As you know, we're in a different White House administration now, with different people, with different priorities. I did a blog recently about CMS Administrator Chiquita Brooks-LaSure and CMMI Director Liz Fowler, and how they wrote a blog in Health Affairs, basically, as I put it, saying there's a new sheriff in town. And one of the things that they're focused on, they basically said, we're looking at two things fundamentally. It was a long blog, but two key points. One is we're going to really focus on models that work the best. And two, we're going to focus on health equity. Now, one of the things that's interesting to me is that there was this back and forth for a couple of years between SEMA Burma and some of the organizations representing ACOs, like NACOs, for example. And it got a little bit contentious. What it seems to me as though they were saying, and this was really interesting in the blog, because Administrator Brooks-LaSure did not actually cite MSSP as one of the most successful ones. She cited Pioneer, which I thought was really interesting. And basically, the implication I got from that is that they are right now taking a rather rigorous look at what works and what doesn't and why. What would you like federal healthcare officials to be thinking about as they look at these APMs? You lead an organization that has been dramatically successful. You have a wonderful culture. you've documented great results. What do you think that the feds need to really be thinking about right now?
I think that one of the problems that we face in healthcare today is that the alternative payment models have not fundamentally really changed the way we deliver healthcare. We are still, in many ways, a fee-for-service model with layering of budget-based care and alternative payment models on top of that. And I think because of that, we still have a primary care crisis in the country, and we still have a behavioral health crisis in the country. And although I am an absolute believer that measuring quality and paying for quality improves the care that we give, that measuring patient experience and measuring provider experience and wellness are critical to the success of the healthcare system, I don't think we've matured to the level that we really are measuring any of it accurately and correctly. We do measure some things well, and some of our outcome measures, I think, are valuable and helpful. But the reality is that take, for example, quality measurement. The reality is that when I look at my organization and where we fail, for example, in blood pressure control, we fail because people don't push drugs for blood pressures that are 140 to 144 over 90. And many of those people are older, not younger. I'm not sure that's good healthcare to push drugs and push their blood pressures down. So when they get up in the middle of the night, their blood pressure drops, they fall and break a hip. I'm not sure we know what the right answer is. And I don't think we've figured out how to measure blood pressure, for example. Diabetes is a little bit easier. Cancer screening is a little bit easier. But I don't think we've moved quality measurement to where it should be. I think we need to figure out something different about primary care capitation models that really take away some of the burden of documentation from primary care physicians and allow them to focus more on taking care of the patients. You know, the most common complaint we hear from patients is our doctor is typing rather than looking at me.
Absolutely. Yeah.
We have to fix that.
Yeah, I agree. As a good friend of mine would say, I violently agree. I think when I talk to people, the thing to me that's really interesting is that ultimately the only way some of this is going to work is if we move in the direction of full capitation. Whether or not we do full cap is a different question, but if we can keep moving in that direction, we're going to shift the incentives. Right now, there's this problem that everyone calls 1 foot in the boat, 1 foot on the dock or the shore. And I had an interview yesterday that was so interesting because I realized I was thinking about it backwards, that actually you want to be in the boat, not on the shore. I kept thinking you want to be on the shore, not in the boat. So I kind of had the visual metaphor backwards. But I was talking with someone at a very successful ACO out west, and he basically said, essentially, we have to treat all our patients as though they're in a capitated plan, right? Once you start doing that, things really shift, because then you're shifting the entire care delivery culture. And can you just share with us a little bit of wisdom about that thought?
Well, I think there are a couple of things that I think. One is, if you look at what is happening across the country, many of the ACOs, alternative payment models, are hospital driven. And hospitals need to keep their beds filled. They need the ambulatory surgery centers filled in order to be profitable and have a margin. And that in and of itself is a problem. They will always do better with having a bed filled than making a small surplus. And until we can shift that, I think we're not going to get the incentives correct. I think for physicians, we also need to figure out not just how to do a capitation model for primary care, but how to layer it so that a primary care doctor gets reimbursed for having a social worker in their office, a case manager in their office, a health coach in their office. The infrastructure costs that we have today are part of the alternative payment model surplus.
Yeah.
They're not counted correctly. You only get that paid for if you make surplus. You only make surplus a year and a half after the fact. So it's, again, a complicated incentive that we need to fix.
Yes. Absolutely. I agree with you completely, Doctor. Can you just leave us with a piece of advice? You have so much wisdom to share. Just a piece of advice for those who are not as far along in their journey as your organization is, to encourage them forward.
I think what has always encouraged me the most about what we do is, one, you have to have data. And we've talked about this before in the early days. If you don't have data, you really can't know how you're performing, where the gaps in care are. And it's not about how you are performing financially. When I go to meetings, understandably, the CFOs of the systems worry that they don't know how they're performing financially till almost the end of the year or into the next year, when there's very little you can do about it. But what you really need data for is to be able to identify early on in the year where are the gaps in care and where are the people who are most at risk to fall through the cracks, or in bad control, or are frequent flyers in the emergency room or readmissions, so that you can intervene and help them get better care. You need that kind of clinical data, not financial, but clinical data. You also need to have an infrastructure that can help you deal with that can intervene and make changes. And what you can't do is expect that you're going to be able to say, if I do A, I will get an ROI of B, because I can always make up the numbers. What you have to do is put together a program of intervention, and it's the whole program that works. It's not one individual thing. It's the pharmacy program that keeps people on their meds. It's the care manager that reminds the patient to go to the appointment. It's, a whole slew of things that help, not one thing.
Absolutely. Well, I just want to thank you so much, Dr. Spivak. You always share such great wisdom. I know that this will be incredibly beneficial for our audience. If they were here on our Zoom call, they would be applauding.
Oh, well, thank you. And I'm really hoping that next year we can be in person and then answer questions.
Absolutely, absolutely. And so thank you so much, Dr. Spivak, for your time, your expertise, your wisdom, and your generosity.
Always a pleasure. Stay well, everyone.
You too. Thank you very much. Thank you.